This is number 25 of 100 bitch spay videos numbers 1 to 24. Have in-depth tuition and explanation. If you have not watched these videos, you will gain more by watching them first. And then the videos 25 to 100 are of limited verbal instruction and caption, as you should now know the basis of the uterine separation technique, but there is never a set rule. You will see different ways of addressing problems and different combinations of knots. Each bitch spay is slightly different. Always tend high and expect a large spleen below. Keep the wound small, so you can just exteriorize the uterus, without abdominal fat and intestines coming out. This uterus was difficult to drag up. I tend to aim for just in front of the bladder, slide off the vertebrae and try and hook the uterus, which runs parallel to the vertebrae. You can see the bulge. As I slide the uterus up the body wall, push all abdominal fat back in. If the uterus is covered in mesenteric fat, push the fat cranially, and that will eventually leave you with just the uterus. I have slowed this part down so you can see how I grasp the ovary. I hold the uterus with my right hand, then push down on the abdominal wall with my left hand. This exposes the ovary. I pinch it with my left hand and then pull the ovary up and swap hands. So I am pinching the uterus with my right, ready to break the suspensory. You have to have confidence in pulling the ovary. You must specifically just pull on the ovary. This is perfectly safe, as the ovary has the suspensory and renal ligaments attached. These ligaments take the strain and not the vessels. The key is to just pull the ovary. If you are holding below the ovary, you could rip the vessels off. If you are holding part of the uterus, which is just behind the ovary, again, this could snap off. You must just pull on the ovary. This is the right side of the dog, so the suspensory is easier to break. Hold the ovary in your right hand, so the suspensory ligament is taut. And with your left index finger slide down the suspensory. Remember, it's the suspensory, not the renal, at the base insertion, or as close to as possible. Push the ligament downwards. If you are worrying whether you have the suspensory or the renal, in 90% of dogs, the ligament which is taut is the suspensory. In 10% the tension on the renal and suspensory can be equal. Remember, the suspensory inserts from the top of the ovary to the last rib, the renal inserts from lower part of the ovary to the kidney. When you slide down the suspensory, you should feel your finger sliding around the back of the kidney. If you break the renal by mistake, it's not all over. Don't panic, you just have to be extra cautious, as when you pull on the ovary, there is no ligament to protect the vessels. So you could tear vessels with a broken renal ligament. There may be a slow bleed from its ovarian insertion point. Just be extra cautious and you will be okay. Make sure your window is not near the ovarian vessels. To get good clearance of the ovary, it is vital you break the suspensory ligaments correctly. Place the clamp below the ovary and walk it down. You do this by holding the ovary and pushing the clamp down, little by little. Close and hold the clamp together each time you move it down. But don't click it when you feel it is far down and have removed anything else from the clamp, like skin, fat, mesentery, etc. Then click it together. I always try and get about an inch below the ovary. This can be a struggle with tighter ovaries. Separate the uterus to improve exposure and visibility. Place your first millers, make sure it is tight, then move the clamp closer to the ovary, and place your second millers. It doesn't have to go in the crush bed, position is more important. With your ligatures, make sure they are not too close to the clamp, as this will affect tightness. If you can see yourself cutting through the fat as you tighten the ligature, don't worry. This is good, it shows you are getting it tight. Never hold back, as the suture will never cut through the vessels. I have had new graduates claim they have cut through the vessel. This has not been true. What they have done is slip off the end of the suture, or the suture has broken and snapped off. This has then tugged on the ovarian pedicle, breaking it. Before you move the clamp up, you have to release the top clamp. Blood is trapped between the clamps, so I am just swabbing up the blood. It is good to visually check your first millers. You want to see the tissue pinched tightly. As you move the clamp up, hold the ovary to check your placement clears the ovary. Another advantage of the technique is that we can test for bleeders. I remove both the clamps and check. After the aorta, the ovarian artery has the highest pressure. So if the ligatures were loose, the blood would be spurting out and can even hit the ceiling. If you have any concerns, replace the clamp and add another ligature. If all is well, then replace the clamp and remove the ovary with the blade, flush to the clamp. We have already checked the ligatures, so we can just release the pedicle. With other techniques you have to try and hold onto the pedicle before it enters the body. And if you need to place another ligature, trying to get the pedicle up safely is not an easy task. I would recommend always tying off your broad ligament rather than tearing it, as no blood is better than some blood. Keep the uterine vessel with the uterus, and this will be ligated later. Rotation of the clamp helps with placement of the surgeons, so it's not too close to the clamp. Push down on the body wall with your left hand and grasp the ovary, then transfer into your right hand. Keep tension on the suspensory ligament and break it by pushing down at the insertion at the rib, or pushing laterally on the ligament, or hooking your finger under the ligament and push upwards. I often find the last one is the more effective. On the left side the ligament is thicker and harder to break. Remove the top clamp, swab the blood, and then raise the ovarian clamp closer to the ovary, and place the second Miller ligation. The top clamp is removed and the ovarian clamp moved closer to the ovary, and then the top clamp is returned. See how you have good exposure of the ligature and the ability to nudge it down. You can also watch the tightness of your ligature as it digs into the pedicle. The clamps are removed and as there was no bleeding, the ovarian clamp was replaced and the ovary removed with a blade. I always try and get my broad ligament ligation down low, so it removes away the fatty ligament, so it is not included when you ligate the uterus. Again rotate the clamp, so the ligature does not form near it, and again to can watch your ligature dig into the fat, and see it is tight, with a surgeon's knot. The double throw bounces back a little, so pulling the first one throw tight is very important, as this then tightens the double throw. With some of the bitch spays, you will see how a miller's knot can sometimes cut through the uterus. For this reason I always place a surgeon's first, as this is unlikely to cut through. And means if your miller's does cut through, then at least you have one ligation. If a miller's cuts through, still finish and use the millers. Despite cutting through the uterus, the uterine vessels will be ligated. Unfortunately, during my career, I had to go into many bitch spays, where someone else has done the spay. You would always expect the bleed to be ovarian, but it's actually from the uterine ligations. The reason for this is that with an ovarian bleed, you know there is a problem with the abdomen filling up with blood or blood spurting out. With a uterine bleed, they tend to be used as slow bleeders. Also, when people check for a uterine bleed, the uterus is usually trapped over the muscle like in the picture. And when released back into the body, the vessels are not trapped and start bleeding. There are 3 very important tips I would like to pass down. The first sign of a possible problem is a slow post-anesthetic wake up if blood is dripping from the abdominal wound, and the blood does not clot. This means the blood is coming from the abdomen, but if clots form, the bleed is from the fat or skin. If you have to go into a bleeding abdomen and the abdomen is full of blood, feel for the jelly clot wherever this is. This pinpoints the bleed location, so you can add a third ligature. In this case, it is an extra millers with the surgeons alongside. Alternatively, you could add a traditional transfixing on each side around the uterine vessel, or a 2-strand transfixer, which is a better alternative. You will see these in other spay videos. So this is the part where a potential uterine bleed could be trapped in the muscle and only starts bleeding when released. Closure in rescue dogs has to be safe, as they don't get the post-op rest like private dogs in a forever home. Mainly eye close with cruciates, occasionally continence with a knot placed halfway, and then rarely simple interrupted. We're always on a budget. But I quite like the dreaded cat cut, reasons being, the knot security is excellent, and also you can control the knot tension and not place them overly tight. With new graduates using PGA or PDS, I used to see a lot of post-op muscle swelling due to sutures being too tight. This was very rare to see with cat gut, so there were less post-op problems with the dreaded cat gut. I place a cruciate at either end first. This is because the muscle opening may underrun the skin, so placing one codland cranially means it is easier to place them now as better visibility, rather than at the end of a suture pattern. Remember to start the skin deep superficial deep, so the knot forms under the fat, and first pass is deep superficial to keep the knot under. To help reduce the dead space, I take a bite of the muscle. To finish the pattern, you can use an Aberdeen or a surgeon's. Just snip the short tail, so you can now run into the intradermals. With the same suture, I pass the needle caudal to the knot, through the fat, and exit in the intradermal position. This helps to prevent the knot sticking up through the wound. Try to leave a small hole at the end, so you can bury the intradermal knot easily. Finish with a surgeon's or an Aberdeen. Risks versus benefits. An Aberdeen is easier to bury, but can fall apart. A surgeon's is harder to bury, but will not unravel, research shows. Finishing the Aberdeen with a 2-pass and not a 1 reduces the chance of unravelment. Also try and leave a longer tail with an Aberdeen. For burial, pass the suture near the point of the knot. The needle needs to glide through, or the knot will not bury. Also when burying, push the skin over the knot and gently pull on the suture. If all else fails, place a large needle, as this will make a larger passage for the knot to follow. It must bury as the wound heals edge to edge. I have not got a good burial, so I add an intradermal mattress suture to close the wound edge better.